Guys, so my name is Malithi. I'm one of the PGY2s. I'm going to be presenting on thrombolytics in PE. Special thanks to Dr. Shu, Dr. Kopchak, and Dr. Turner for helping me out with the slides. So before we start, I have some poll questions up. I have about a 50% faith in that it'll actually work and not have any glitches. But if anyone has Wi-Fi, you can log on to poll.com/MALITHIN 976 so that throughout the slides hopefully it works, that you can answer some questions. The link will show up again on the slides. So first, before we get started, I'm kind of just going to review the pathophys of how PE works and why it sucks. You have pulmonary embolism, which is essentially a clot in the pulmonary vasculature, which then leads to, firstly, increased pressure in the right ventricle. Why is that? Is because there is an increase in pulmonary vascular resistance. This then leads to two things. So one of them would be right ventricular hypokinesis and dilation, as well as right ventricular wall tension. In terms of the hypokinesis and dilation, it leads to a decrease in left ventricular preload, and that occurs because there is a decrease in right ventricular cardiac output, as well as intraventricular septal deviation towards the left ventricle. In terms of the right ventricular wall tension, this causes right ventricular ischemia plus minus infarction due to an increase in oxygen demand of the right ventricle myocardium, which then leads to decreased coronary perfusion due to a decrease in oxygen supply in the right ventricular myocardium. Ultimately, the decrease in left ventricular preload leads to systemic arterial hypotension due to a decrease in left ventricular cardiac output, which then further contributes to a decrease in coronary perfusion, as well as that right ventricular ischemia also contributes further to the right ventricular hypokinesis and dilation. The pathophys behind pulmonary embolism is essentially this vicious cycle that just everything worsens each other. So this is one of the first questions is someone could tell me if it's working? Of course it's not. Well, can anyone on Zoom see it?
Yeah, I can see it on my phone.
I can see it on my computer.
See it on computer? Okay. But somehow this is not loading. So I guess if anyone can try to answer, I can see on this. I don't know why it's not.
What's the URL?
So it's poll.com/MALITHI 976. I tried to make a better one, but then you had to pay. All right, well, we tried. It's a rhetorical question. Basically, the question for those in person and you're seeing on your phone, submassive P is defined by either hypotension, evidence of RDV dysfunction, evidence of myocardial necrosis, or both B and C, or none of both. So we'll just go over the definitions of some subgroups of P, which is massive versus submassive. So initially, the definitions were actually based on kind of clot burden, but then the definition kind of slowly changed to clinical presentation. So in terms of massive PE, that would be described as acute PE with presence of hypotension without any other cause, such as like sepsis underlying hypotension, or acute PE with persistent bradycardia, or acute PE with pulselessness. Submassive PE is defined as acute PE without hypotension, but evidence of either right ventricular dysfunction or myocardial necrosis. Right ventricular dysfunction would basically be defined as right ventricular dilation on CT or echo, EKG changes such as anteroseptal ST elevation or depression, or new right bundle branch block, or elevation of BNP. Myocardial necrosis could be signified by an elevation troponin. Again, it's not working, but basically the question's asking thrombolytic should be considered in submassive P, massive P, or non-massive P, or both A and B. So this is kind of controversial. This is kind of where the controversial topic starts. ACEP says there's not really enough evidence. The American Heart Association says you should consider it in submassive if they have evidence of like poor prognosis, if they have a very low bleeding risk. So in terms of disadvantages, so the controversy, like I said, is with submassive PE where there's more gray line. It's more accepted to use thrombolytics more in massive PE since they're more hemodynamically unstable. In terms of advantages versus disadvantages for using thrombolytics, one disadvantage that everyone pretty much talks about is the bleeding risk. So the risk of interstitial hemorrhage or any other hemorrhage. In terms of evidence behind that, in a PITHO trial, the PITHO trial in 2014, which is a double-blinded, multi-center RCT study, looked at about 1,000 patients and looked at basically heparin plus placebo and heparin plus tenecteplase. They found that there was major bleeding, so a significant increase of bleeding risk with tenecteplase, about 6.3% versus a placebo group, which is about 1.5%. Also, some studies have shown that there is really no difference in like mortality from just anticoagulation alone versus anticoagulation plus thrombolytics, such as in the MAPIT-3 trial, which is also another double-blinded RCT. They looked about 256 patients, again with heparin plus alteplase or just heparin alone, and they showed no difference in hospital mortality, which is about 3.4% versus 2.2% in the placebo group. And both of those trials did use full dose anticoagulation, which is 100 milligrams TPA, which we'll talk about later. In terms of advantages of thrombolytics, there has been studies that also show like decreased clot burden, such as a study there was a small study by Levine et al., which is about a study of 58 patients. They used half dose TPA, so TPA versus heparin alone, and their primary outcome that they looked at was clot burden on VQ scan at 7 days and at 28 days, which showed a decreased clot burden in patients that received thrombolytics versus just anticoagulation alone. Decreased long-term pulmonary hypertension has also been shown in some studies, such as the MOPIT trial, which looked at, I believe, 121 patients, and again compared just heparin versus placebo plus versus thrombolytics. They basically defined pulmonary hypertension by echo at 28 months and showed a long-term reduction in the incidence of pulmonary hypertension in those patients that received thrombolytics. You can also show hemodynamic stability. The study I mentioned before, the PITHO trial, which did show increased bleeding risk in patients who are given thrombolytics, also did show that there was a relative risk reduction, 56% of having either death in the hospital or hemodynamic instability after 7 days when treated with thrombolytics versus just anticoagulation alone. Again, this question, I'll just ignore it. So in terms of thrombolytic dosing regimens, most studies have either worked full dose or half dose. The MOPET trial that I described before, showing a decrease in incidence of pulmonary hypertension, did use half dose, and they showed no increase in bleeding risk, likely due to this half dose. There are some meta-analysis that showed that there is a lower bleeding risk when you do half dose, and there's no change in outcomes. So no statistical difference in either mortality or recurrent PE. There was one prospective study by Lang et al., which is a multi-center randomized control trial, looking at about 118 patients, which showed compared full dose versus half dose, which showed no difference in outcomes about 24 hours and 14 days. And they looked at things like improvement in right ventricular function and lung perfusion deficits, which were better which were the same in both doses, but less bleeding risk in the half dose patient population. Other treatment modalities that you would want to look at, especially in those patients that you think have a higher bleeding risk when you're considering using thrombolytics, are catheter-directed thrombolysis and mechanical thrombectomy. In terms of the catheter-directed in terms of both of these methods, there's not as much studies supporting the maybe decreasing mortality using these options, but I think it's something to consider. In terms of the catheter-directed thrombolysis, you infuse a thrombolytic agent near the clot to help break up the clot, and mechanical thrombectomy would be essentially clot retrieval. That's about it. So in summary, I think it's important to consider that PE is a vicious cycle So even though there's a lot of controversy between using thrombolytics in submassive PE, I think it's still important to consider due to the kind of complications of possible long-term pulmonary hypertension in these patients and further down the line, even though there might not be some direct effect. There's no clear-cut answer for thrombolytics versus just anticoagulation alone in submassive PE, but the studies kind of show that, at least from my interpretation of having both these studies, that maybe if you have a high-risk patient, you want to consider half-dose thrombolytics in these high-risk patients to help reduce clot burden and provide more hemodynamic stability. And important to consider alternatives. I don't know if we offer these at our site, but if you have a high-risk patient that has a high bleeding risk, then you might want to consider options for catheter-directed thrombolysis and mechanical thrombectomy. I think that's about it. I might have rushed through just a little bit. I know where David is. If anyone has any questions, these are my references. That's about it. Any questions or any?